Hello and welcome to this AstraZeneca presentation, Shifting to Inhale Corticosteroid-Containing Rescue Therapy in 2024. My name is Dr. Neil Skolnick, Professor of Family and Community Medicine at the Sidney Kimmel Medical College of Thomas Jefferson University and Associate Director of the Family Medicine Residency Program at Jefferson Health, Abington.
Hello, my name is Dr. Wendy Wright, a family nurse practitioner and owner of Wright and Associates Family Healthcare, a primary care clinic in Amherst, New Hampshire. We are delighted to be here with you today. Please note, this presentation does not qualify for any form of continuing education credit. Thank you for joining.
The objectives for this presentation include the following. Highlight the burdens of asthma exacerbations and systemic corticosteroid exposures in the United States. Evaluate the role of variable inflammation in the occurrence of asthma exacerbations. And review recent recommendations from GINA and NAEPP. And finally, examine data on a rescue therapy treatment option. When it comes to clinical care of asthma in the United States over the last few decades, how do you think we're doing? Well, from the year 2000 until now, a number of new maintenance therapies have been FDA approved for asthma. Fixed-dose combination inhaled corticosteroid plus long-acting beta-2 agonist, or ICS-LABA inhalers. An anti-IgE monoclonal antibody, long-acting muscarinic antagonist or LAMA inhalers, monoclonal antibodies inhibiting interleukin-5 or interleukin-5 receptors, a monoclonal antibody inhibiting the interleukin-4 and 13 receptors, a fixed dose combination ICS-LABA-LAMA, and a thymic stromal lymphopoietin or TSLP antagonist.
So we clearly see that over the past 20 plus years, a growing understanding of the pathophysiology of asthma and the role of airway inflammation has led to the development of new maintenance therapies for people with asthma. Yet, despite these advances, the burden of asthma exacerbations persists. Real-world evidence utilizing administrative claims data within 2010 to 2017 has shown that despite adherence to maintenance therapy, despite asthma severity, and despite level of symptom control, as reflected by measured SABA use, people with asthma are at risk of exacerbations. In fact, data from 3 real-world studies has shown that up to 50% of people with asthma in the United States experienced at least one exacerbation in a given year. Now let's examine some recent national asthma data showing the impact of asthma exacerbations in the United States. In 2021, approximately 9.8 million attacks were reported by patients with asthma. In 2020, there were approximately 990,000 emergency department visits and 95,000 hospitalizations due to asthma. When examining the science behind why so many people with asthma are at risk for an exacerbation, I always feel it's essential to go back to the fundamentals of airway inflammation and bronchoconstriction to explain how symptoms may evolve. Airway inflammation and bronchoconstriction are central to the burden of asthma. In patients with asthma, we can see tightened airway smooth muscles, airway wall swelling, infiltration with inflammatory cells, and mucus gland hypersecretion. These changes can result in airway luminal narrowing and symptoms such as wheezing, shortness of breath, chest tightness, and cough. And importantly, the inflammation and symptoms of asthma vary over time and intensity and can progress to asthma exacerbations.
However, a window of opportunity may exist to help prevent an exacerbation if symptoms and inflammation are treated concomitantly. Let's look at the impact of rising inflammation and how it can result in decreased lung function, increased symptoms, and increased use of rescue therapy. Here on the right, we present a figure from the FACET study, an exacerbation reduction study in response to ICS with or without a LABA. This study examined the pattern of peak expiratory flow, PEF decline, symptoms, and rescue beta-2 agonist use in the 425 exacerbations that occurred during the study. You can see that peak flow fell while symptoms and rescue use increased in the 10 days before an exacerbation occurred, and they returned to pre-exacerbation or near pre-exacerbation levels over the subsequent 2 weeks. We know that asthma is a variable inflammatory disease, and as asthma symptoms worsen prior to an exacerbation, patients increase use of their fast-acting bronchodilator, which can further worsen inflammation if used alone without ICS. Thus, interrupting a rise in inflammation may prevent the occurrence of an exacerbation and avoid the need for systemic corticosteroids.
Now, here is a great way to visualize the unpredictable nature of inflammation and symptoms. Patients with asthma experience episodic exposures to allergic and non-allergic triggers that can result in the variability of inflammation and symptoms. Treatment with anti-inflammatory maintenance therapy is intended to address baseline levels of inflammation, as shown by the dashed line in the illustration. However, maintenance therapy may not always address unpredictable changes in airway inflammation. Furthermore, while the treatment of breakthrough symptoms with SABA alone addresses bronchoconstriction, it does not treat inflammation.
That's right. And as we know, worsening symptoms can progress into an exacerbation, which may lead to the use of systemic corticosteroid therapy, or SCS for short. While treatment of exacerbations with SCS is often necessary and effective, observational data have suggested that standard bursts of systemic corticosteroids may result in a cumulative steroid burden that impacts future health. Shown on the left is data from an observational study by Price et al., demonstrating the potential risks for developing adverse health conditions associated with various levels of cumulative SCS exposure. The risk of developing conditions such as diabetes, anxiety, and depression increased as exposure to SCS accumulated over a lifetime. Statistical significance became evident when cumulative lifetime SCS exposure reached a threshold of at least 500 milligrams. A greater risk occurred, and more adverse conditions such as osteoporosis and cardiovascular disease were observed, with cumulative exposures between 1,000 milligrams and less than 2,500 milligrams. In a separate, retrospective cohort study and self-controlled case series, it was observed that within 30 days of oral corticosteroid initiation, the incidence of adverse events such as sepsis, venous thromboembolism, and fracture approximately doubled. Thus, treatment of exacerbations with SCS contributes to the burden of disease. Keeping this in mind, how have asthma expert recommendations evolved to try to prevent this level of corticosteroid use while still addressing inflammation, which plays a central role in asthma?
Well, Treating symptoms and inflammation concomitantly with rescue or reliever therapy that includes both an ICS plus a fast-acting bronchodilator is supported by the latest recommendations from the Global Initiative for Asthma, or GINA, and the National Asthma Education and Prevention Program, or NAEPP. As a reminder, SABAs and formoterol are considered fast-acting bronchodilators. In fact, as you see on the left, NAEPP guidance from 2020 incorporates this concept at steps 2, 3, and 4 as preferred therapy, with concomitant as needed SABA plus ICS listed as a recommended option at step 2, and ICS formoterol maintenance and rescue recommended at steps 3 and 4. On the right, you can see that GINA also supports this approach with ICS formoterol as the preferred reliever across all treatment steps in track 1. In GINA, SABA-only treatment of asthma is no longer recommended. As GINA states, the risk of severe exacerbations and mortality increases incrementally with higher SABA use, independent of the treatment step. It is important to remember that ICS formoterol is not approved in the United States for maintenance and rescue therapy or for as-needed rescue only. The recommendations for ICS formoterol are based on clinical data evaluating the use of formulations and strengths not approved and not available in the United States.
GINA also includes recommendations for the concomitant use of SABA and ICS in its Track 2 controller and reliever treatment steps for patients of all disease severities. The reliever options recommended in this track are as needed ICS SABA or as needed SABA. GINA also states that before considering a regimen with SABA reliever, check if the patient is likely to adhere to daily controller treatment. As you see in Track 2, Step 1 of GINA, low-dose ICS whenever SABA is used, in combination or separate inhalers, is recommended. In Steps 2 to 5, GINA recommends daily ICS containing maintenance therapy with as-needed ICS SABA or as-needed SABA for reliever therapy. GINA emphasizes the importance of a personalized asthma management plan involving a continual cycle of assessment, adjustment of treatment, and review. The plan should be developed according to an individual patient's need to achieve the goals of asthma treatment.
Let's now transition to a review of clinical data for AirSupra, a fixed-dose combination medication where each inhalation consists of 90 micrograms of albuterol and 80 micrograms of budesonide. AirSupra is an ICS-based rescue option that was designed to shift the treatment paradigm and help address exacerbations and systemic steroid exposures for patients with asthma. Please see the full prescribing information, including patient information, for AirSupra, available at www.airsupra.com or at www.azpicentral.com.
AirSupra was approved by the FDA in January of 2023 and is a combination of albuterol, a short-acting beta-2 adrenergic agonist, and budesonide, a corticosteroid. AirSupra is indicated for the as-needed treatment or prevention of bronchoconstriction and to reduce the risk of exacerbations in patients with asthma 18 years of age and older. The recommended dose of AirSupra is 180 micrograms of albuterol and 160 micrograms of budesonide, administered as 2 inhalations of Airsupra, albuterol and budesonide, 90 over 80 micrograms. Patients are instructed not to exceed more than 6 doses or 12 inhalations in a 24-hour period.
Before reviewing the clinical data, let's focus on some select important safety information. Contraindications to using Airsupra include hypersensitivity to albuterol, budesonide, or any of the excipients. Deterioration of asthma can occur acutely or chronically. So if a patient continues to experience symptoms after using Airsupra or requires more doses of Airsupra than recommended, it may be a marker of asthma destabilization. Airsupra can produce paradoxical bronchospasm, which may be life-threatening. If paradoxical bronchospasm occurs, Airsupra should be discontinued immediately and alternative therapy instituted. When associated with inhaled formulations, it frequently occurs with the first use of a new canister. Airsupra, like other drugs containing beta-2 adrenergic agonists, can produce clinically significant cardiovascular effects in some patients and may need to be discontinued. Airsupra should be used with caution in patients with cardiovascular disorders, especially coronary insufficiency, cardiac arrhythmias, and hypertension. Please see additional safety information at the end of this presentation, as well as the full prescribing information, including patient information.
Wonderful. We're now ready to discuss important data from the Mandala trial, a pivotal phase 3 clinical trial used to support the approval of as-needed therapy with a combination of albuterol and budesonide, Airsupra.
The Mandala study was designed to evaluate the efficacy and safety of albuterol in combination with budesonide, given as needed, compared to as-needed albuterol as rescue therapy in patients with uncontrolled, moderate to severe asthma. This event-driven study enrolled symptomatic patients who had experienced at least one severe asthma exacerbation in the previous year and were receiving maintenance therapy to treat moderate to severe asthma, as defined by GINA, for greater than or equal to 3 months prior to study entry. In Mandala, patients were randomized to one of 3 treatment groups: albuterol budesonide, 180/160 micrograms, given as 2 inhalations of 90/80 micrograms. Albuterol budesonide, 180/80 micrograms, given as 2 inhalations of 90/40 micrograms, or albuterol, 180 micrograms, given as 2 inhalations of 90 micrograms. Randomized patients continued their background maintenance therapy throughout the trial, which we will detail shortly. It is important to note that while patients 12 to 17 years of age were included in Mandala, Airsupra is not approved in this age group. Therefore, efficacy results are only presented for adults 18 years of age or older. Since albuterol budesonide 180 over 80 micrograms is not an approved dose, this presentation will not include results for this arm of the study.
Here we have key inclusion criteria for the Mandala trial, which included symptomatic patients with moderate to severe asthma, at least one severe asthma exacerbation in the previous year, asthma maintenance therapy for 3 or more months with stable dosing for 4 or more weeks prior to screening. Required background maintenance therapy included medium to high dose ICS or low to high dose ICS LABA, with or without an additional controller, and pre-bronchodilator FEV1 of 40% or greater to less than 90% of predicted normal and confirmed reversibility to albuterol. Select exclusion criteria included chronic obstructive pulmonary disease or other significant lung disease, SCS use within 6 weeks prior to screening, chronic oral corticosteroid use, at least 3 weeks of use within 3 months prior to screening, and biologic treatment within 3 months or 5 half-lives of screening.
As we can see here in the adult efficacy population, which included a total of 2,940 patients, key baseline demographics included a mean age of 52 years, 66% of the patients were female, 82% were Caucasian, and 25% were of Hispanic or Latino ethnicity. Key baseline clinical parameters included a mean pre-bronchodilator percent predicted FEV1 of 63%, a mean percent reversibility in FEV1 of 28%, and within the 12 months prior to screening, 80% of these patients had one severe exacerbation and 20% had more than one severe exacerbation.
In terms of background ICS-based maintenance therapies, approximately 30% of patients were receiving low-dose ICS-LABA or medium-dose ICS. 40% were receiving medium-dose ICS-LABA or high-dose ICS, and 28% were receiving high-dose ICS-LABA. Commonly used ICS maintenance medications included beclomethasone dipropionate, budesonide, fluticasone furoate, fluticasone propionate, and mometasone furoate. And throughout the study, patients reported a mean adherence of 75% to their ICS-based maintenance therapy.
Now that we know a little more about the Mandala study design and patient population, let's turn to key efficacy results for the participants who were 18 years of age and older. The primary endpoint was the time to first severe asthma exacerbation, with severe exacerbation defined as an asthma clinical worsening leading to one of the following: a 3-day course of systemic corticosteroids or corresponding single injectable dose, an emergency room or urgent care visit due to asthma that required systemic corticosteroids, or hospitalization for at least 24 hours due to asthma.
Note the divergence between the albuterol budesonide 180 over 160 micrograms arm, as shown by the darker blue line, and the albuterol 180 micrograms arm in the teal line on the Kaplan-Meier curve shown here. The data shown are from the pre-planned on-treatment efficacy analysis collected while patients were on randomized treatment prior to treatment discontinuation or change in maintenance therapy. Data was censored at the time of discontinuation or change in therapy. Albuterol budesonide 180 over 160 micrograms significantly reduced the risk of severe asthma exacerbations in a time to first severe exacerbation analysis by 28% compared to albuterol 180 micrograms, with a hazard ratio of 0.72. A 95% confidence interval of 0.6 to 0.86, and with a statistically significant p-value of less than 0.001.
Having now seen the efficacy in the primary endpoint, Were there any significant findings in key secondary endpoints?
Yes, in fact, there were also significant results in key secondary endpoints of the study. The annualized severe exacerbation rate was reduced by 24% for those receiving albuterol budesonide 180 over 160 micrograms compared to albuterol alone. The rate ratio was 0.76 with a 95% confidence interval of 0.62 to 0.93 and a statistically significant p-value of 0.008. Additionally, for patients treated with albuterol budesonide 180 over 160 micrograms, the annualized total SCS dose when compared with albuterol was statistically significantly different, p equals 0.001, with a 32% reduction in mean annualized dose per patient. Having now reviewed the efficacy results, let's talk about safety results from the Mandala study.
Absolutely. The safety of any effective approach is paramount. Here, we see a summary of adverse reactions reported in 1% or more of the study population, 12 years of age and older. For albuterol budesonide 180 over 160 micrograms, the incidence of headache was 4.3%, oral candidiasis was 1.3%, and cough was 1%, compared to 4.9%, 0.5%, and 1.1% for albuterol, respectively. The safety profile of albuterol budesonide was similar to albuterol, irrespective of background inhaled corticosteroid dose. Just as a reminder that safety data shown are for patients 12 years or older. Airsupra is not approved for patients 12 to 17 years of age.
To complete the description of Airsupra, the next 3 slides provide additional important safety information. Patients should not exceed the recommended dose. Clinically significant cardiovascular effects and fatalities have been reported in association with excess use of inhaled sympathomimetic drugs. Hypersensitivity reactions, including anaphylaxis, can occur after administration of albuterol sulfate and budesonide, components of Airsupra. Discontinue Airsupra if the reactions shown on the slide occur. Airsupra should be used with caution in patients with certain coexisting conditions such as convulsive disorders, hyperthyroidism, or diabetes mellitus, and in patients who are unusually responsive to sympathomimetic amines. Significant hypokalemia may occur in some patients from the use of beta-adrenergic agonists, and possible immunosuppression and potential worsening of infections from the use of ICS could occur. Use with caution. A more serious or fatal course of chickenpox or measles can occur in susceptible patients.
Additionally, oral pharyngeal candidiasis has occurred in patients treated with ICS agents. Advise patients to rinse their mouth with water if available. Hypercorticism and adrenal suppression may occur with very high doses in susceptible individuals. Reduction in bone mineral density has been observed, and glaucoma and cataracts have been reported with long-term administration of ICS. Orally inhaled corticosteroids, including budesonide, may cause a reduction in growth velocity when administered to pediatric patients. However, note the safety and effectiveness of Airsupra have not been established in pediatric patients, and Airsupra is not indicated for use in this population.
The most common adverse reactions reported for AirSupra with an incidence of greater than or equal to 1% were headache, oral candidiasis, cough, and dysphonia. AirSupra should be administered with caution to patients being treated with strong cytochrome P450 3A4 inhibitors, short-acting bronchodilators, beta blockers, diuretics or non-potassium sparing diuretics, digoxin, monoamine oxidase inhibitors, or tricyclic antidepressants. Use AirSupra with caution in patients with hepatic impairment, as budesonide systemic exposure may increase. Monitor patients with hepatic disease. Please see the full prescribing information, including patient information for AirSupra, available at www.airsupra.com or at www.azpicentral.com.
Now let's briefly summarize the important key takeaways from this presentation. First, it is important to address inflammation and symptoms concomitantly to decrease exacerbations. In the Mandala study, when compared to albuterol, AirSupra demonstrated a significant 28% reduction in the risk of severe exacerbations, a significant 24% reduction in the annualized rate of severe exacerbations, and a significant difference in the annualized total SCS dose, with a 32% reduction in mean annualized dose per patient. The most common adverse reactions associated with AirSupra are headache, oral candidiasis, cough, and dysphonia. And finally, to help prevent asthma exacerbations, shift to AirSupra, an ICS-containing rescue therapy.
Thank you so much for summarizing what we discussed today. AstraZeneca is committed to conducting business with the highest standards of integrity and professionalism. If you have comments about this presentation, please contact AstraZeneca at 1-800-236-9933. For medical information requests and access to other AstraZeneca resources, please visit www.azmedical.com. You're encouraged to report negative side effects of AstraZeneca prescription drugs by calling 1-800-236-9933. If you prefer to report these to the FDA, call 1-800-FDA-1088. Thank you for your time and attention. This concludes this program.
The references included in this presentation are available here and on the following slides for your review.